What is up, you guys? My name is Austin Marks and welcome back to my YouTube channel. So I am currently a respiratory therapist who is pursuing the physician assistant career path. On my channel I make videos talking about respiratory therapy, things I do as a respiratory therapist, things involving respiratory school, maybe I talk about the salary, all kinds of things about respiratory therapy. I'm also documenting my journey to becoming a PA. So if you want to see any of that, make sure you guys like and subscribe. So in today's video, I'm going to be continuing my A Day in the Life series by talking about what I do a day in the COVID ICU. So to start off, I just want to say that none of this is medical advice. This is all my experience, things I go through. Now I will talk about medical things that I do. However, if you have COVID-19, you're experiencing any symptoms, don't look at me for advice. Go see a physician as soon as possible. So the first thing I do when I get into work is I go ahead and I get report. So I want to know what's going on with my patients. So I want to know recent ABGs, how's their chest x-ray looking, are we proning these patients, so they're getting better, are they getting worse. I just want to know an overall picture, and that's basically what I get in report, is an overall picture of my patients. So the respiratory therapist who was working before me will tell me about all these patients. So once I'm done getting report, I go straight up to the ICU, and let me tell you, I hit the ground running. There are very few times where I actually get to use the bathroom or eat, so whenever I can, I have to go ahead and do those things. Some days I have 5 minutes to shovel food down my throat. Other days I use the bathroom like 2 or 3 times. I'm always moving, I'm always busy. The COVID ICU is definitely crazy. So in my COVID ICU we have 11 beds. We try to keep at least one open just in case there's an emergency for someone and they need to come in. So the most vents I've ever had at one time, and it's about this right now, is 9 vents. Saying that the other 2 beds or other bed would be a BiPAP or a high flow. Someone that's in critical condition. Everyone who is in the ICU needs critical care, and they need special nurses who are certified in critical care. So I have all these patients, and for each individual patient I need to go ahead and use separate PPE for each patient. So the PPE includes an N95, goggles or some kind of face shield, a gown, and gloves. There are some nurses or respiratory therapists that go ahead and wear a hair cap. I generally don't. Most therapists and nurses will also change their scrubs. Just because of everything that happened in the beginning. I don't, and I've been okay so far, but that's just my experience. So some different things that I go ahead and do with each of these individual patients is I will check on them, check on the equipment, I'll evaluate them, I'll listen to breath sounds, I'll check out their heart rate, their oxygenation, and then if I need to adjust any of the settings on the ventilators, the high flows, the BiPAPs, or even a nasal cannula, I'll go ahead and I will do that. So how can I tell if I need to make an adjustment? So with a lot of these patients, we're getting ABGs on them, which stands for arterial blood gases. So we can either get that through a needle stick or something called an A-line. And how we do that is a needle that is in the wrist, taped down, kind of like an IV, that is in the radial artery or the brachial femoral artery, and it's going ahead and reading the blood pressure at all times, and we can also draw blood from this. So what exactly will a ABG tell me? So an ABG will tell me what the pH of the blood is for the patient. The normal value for this is 7.35 to 7.45. It'll also tell me the CO2 within the blood of the patient. So this is normally 35 to 45. However, with a lot of these patients, both of these parameters, or all the parameters actually, are all out of whack. Another thing we specifically look for with an ABG is the oxygenation within the blood. So this is known as the PaO2. So we can look at the oxygenation through a finger or a forehead or ear probe, and that gives us a rough estimate. However, it doesn't actually tell us what's going on in the blood, and that's why we get an ABG. So sometimes a patient will be satting 90%, but their PaO2 will actually be in the 50, when a normal person's PaO2 should be above 80. However, that can change depending on underlying issues and whatnot. So even though they're satting okay with the finger probe, we may have to turn up the oxygen just because the PaO2 within the blood is getting a little worrisome. We also look at the bicarb. So this basically tells us what the kidneys are doing, if they're compensating for a high or low CO2. Both of these actually affect the pH of the blood. So the higher the CO2 gets, the more acidotic the pH gets, therefore the pH goes down. And with the bicarb, the lower the bicarb gets, the more acidic it gets. So the pH will also go down, and vice versa for those two. ABGs are definitely something that are very complicated. It took me some time to learn in respiratory therapy school. I'm going to go ahead and make another video about that because they're complicated. So if you don't understand right now, that's okay. So as I said, the ABGs will go ahead and tell us what I need to do for these ventilator settings. So a lot of times these people are on crazy settings just because COVID messes them up so bad. Even though we think we're doing the correct thing, we go ahead and they move in the opposite direction. So sometimes it's hard to chase down the CO2, and this is a little difficult because the lungs are just so full of inflammation and congestion. We don't want to create barotrauma, so what this means is the lungs are very stiff. So another reason that we can help with CO2 is through the rate on the ventilator as well as the tidal volume. So we can only go up so high on the rate before it doesn't really do too much. But with the tidal volume, we can only go up so much because we want to be careful of this barotrauma I was talking about, which basically means trauma from the alveoli trying to expand and basically popping out. Just because they aren't meant to do so because they're so stiff and inflamed. So another reason that we can help with the oxygenation is PEEP. So this is a positive expiratory pressure that is inside of the lungs at all times. So this helps with oxygenation. The normal PEEP is 3 to 5, and I've seen people on PEEP all the way up to 22, which is a lot of extra air that needs to be in the lungs. And this is just because they're so inflamed, like I said, and just full of congestion and all the other good stuff. So once I get the ABG and I need to make these settings, I go ahead and I talk to the doctor. We decide what's best for the patient, what way they've been heading, if this has worked, if that's worked, what do we need to do. So then I'll go ahead and make those adjustments. Sometimes it's just little nicks and tweaks here and there. Other times we go ahead and change the setting of the vent or the vent settings that they're on completely. Sometimes we just need to up the oxygen a little bit. Sometimes we decrease the oxygen just because they're doing so well. It all depends, honestly. So how often do we make these changes, or how often do we get blood gases? So generally we get a blood gas on the very sick patients every single day. And sometimes we'll just get it throughout the day because we want to see how the patient is doing overall. Just because we make different adjustments throughout the day just because we want to be on top of our patients. We don't want to just get one blood gas a day and then see how they're doing. That's definitely a no-go. We want to be on top of these patients and make sure they're getting healthy as fast as possible. Which with COVID, it's definitely a slower process than what I'm used to seeing with different disease processes. So it's a little hard, but we want to stay on top of it. So besides just making changes to the settings or getting ABGs, another thing I will also do is I will help prone these patients. So what is proning? That's when the patient basically lays on their stomach. So the mechanisms of this isn't truly understood, but I'm going to go ahead and talk about that a little bit. How it does help, what scientific research has shown us, and what this does is it helps oxygenation. So it's crazy because I've personally seen a patient who is setting 82%, and then I tell them to lay on their side or their belly, and then 93%, just like that, just from laying on their belly. So some ways that this goes ahead and helps the patient is because when a patient is in supine position, the transpulmonary pressure is actually less than when the airway opening pressure. So this means that when a person is on their stomach, it allows more air to open up the lungs, kind of like that PEEP, and just allow better oxygenation. It helps with atelectasis and alveoli that have collapsed. So if you don't know what alveoli are, they are the little air sacs that are in your lungs that help with the oxygenation / CO2 exchange. And it also helps with ventilation / perfusion. So basically this helps with any shunts that may be going on. So a shunt is basically an area in the lungs that don't allow for gas exchange. And those 3 things I got from the American Journal of Respiratory and Critical Care Medicine. So I just want to cite those things, that way someone doesn't come at me for any reason. So we prone these patients, we lay them on their bellies. Okay, so we turn them on their bellies, but then that's that, right? We don't need to mess with them for the rest of the time. Wrong. So a patient is paralyzed, they're sedated, they're laying on their belly, their face is going to be smack there in the bed. It's going to cause pressure ulcers, and we definitely don't want that. So what we do is we go ahead and we turn the head every 2 hours. So it generally takes 2 nurses as well as a respiratory therapist. So we get the airway, we'll get the head, we'll pick it up and turn the head. Sometimes the heads can be pretty stiff just because a person's paralyzed, they're laying there. And then the nurses will lift up the person's body. That way we can turn the head and do everything in one smooth motion rather than fussing with people, because when they wake up, they're gonna be hurting, unfortunately, just because they've been laying on their face. Because normally when you lay on your back, you're obviously laying on the back of your head, but when you're proning, you're laying on your face, and we do have special pillows to relieve the pressure, and that's why we do use proning beds, so we can adjust the pressure points within the body as well. So like I said, we turn the heads every 2 hours, but how often does a person stay prone? So recent studies have shown us that a person stays prone best for 16 hours, and then we turn them back to supine for 8 hours. However, I've had several cases where we turn the person back to supine and they only last maybe 2 hours, and then they just start crashing with their oxygenation, and we need to go ahead and fix that ASAP, so we prone them again. So I know this has been a bit of a long video. So far I've talked about that I make vent changes, I will go ahead and adjust BiPAP settings, I will go ahead and just check on the oxygenations, evaluate the patients, I'll listen to them, I'll make sure that they're doing the best they possibly can. I'll do different maneuvers such as an ABG to see if the patient's oxygenation is changing, if I need to make any setting changes on any of those devices I just mentioned, and I also help prone the patients, which helps with their oxygenation. So all that is a little time consuming, and between all that, I'm also helping do breathing exercises as well as giving nebulizers, any breathing medications. So what's so special about breathing exercises? So as I said earlier, the lungs are inflamed, they're just full of congestion, and some of these people have a hard time taking a deep breath. They say they have pain when they take a deep breath, whenever they do they cough. So they actually want to take a deep breath because this is help opening up their lungs and bringing them back to basically normal compliance, which is exactly what we want. So we give them something known as an incentive spirometer, and what they do with this is they basically wrap their lips around one end and they'll suck in nice and hard, basically just really filling up those lungs as much as they can. I know sometimes it can be painful, however that is something that needs to be done. And we do give that to all of our patients who are on basically just a high flow. If you're on BiPAP, you're already getting enough stuff to open up your lungs, so we don't need to make you do that. Obviously with the vent patients, I'm not going to be doing that either. But with the majority of our patients who have COVID, who are in the hospital, they do get an incentive spirometer. So we also give the breathing treatments through nebulizers, as I mentioned. So a lot of these patients have something known as ARDS, which is acute respiratory distress syndrome. And what this basically is it is bilateral chest infiltrates that go ahead and impair oxygenation that cannot be related to some kind of cardiac issue, because sometimes patients with CHF will have fluid from their heart back up into the lungs. And then ARDS is characterized by alterations by pulmonary mechanics, ventilation, and perfusion, all that VQ mismatch, and severe hypoxic respiratory failure. And unfortunately, that is what a lot of COVID patients are going into who are in the ICU, is they're going into something known as ARDS, which is acute respiratory distress syndrome, which is basically all that infiltrate or gunk in the lungs and the inflammation that is preventing that oxygenation. So these people come in, we get a chest x-ray, a CT scan, and we see that they're in basically ARDS. So do we intubate right away? What do we do? So I'm gonna quickly show you a regular chest x-ray and then a chest x-ray of someone with COVID, and you tell me what you would do, or if you think it's pretty bad. So there's a pretty big difference there, huh? So we do not go ahead and intubate every single patient who comes into the ARDS. Now, intubating a patient is basically the doctor or the provider, such as the PA or NP's call. As a respiratory therapist or even a nurse, they cannot make that call. However, we can call and get a professional consult. That way they can come in and ultimately determine what to do. So we will only take the basic necessary actions that we need to. So if someone does not need to be intubated, we will not intubate them just because. We will put them on nasal cannula first, and then maybe high flow, and then maybe a BiPAP. We can go ahead and skip steps, so if someone comes into the ER, we can put them directly on a BiPAP rather than putting them on a nasal cannula first. Just because from our professional experiences, we know exactly what that patient needs. As I said, we don't intubate everyone, we only intubate the ones who absolutely need intubated. So doing everything I talked about, checking on 11 patients and just basically making circles, going around and around and around, checking on them over and over again. These patients also desat very quickly. So what I mean by that is 1 minute they will be perfectly fine, and then the next we need to rush in the room. Obviously we put our PPE on and everything before we go in the room and make sure that they're doing okay. There are so many factors that can make a person basically decompensate or just go downhill real quick. And one of these is that patients in the middle of the night will sometimes, or even throughout the day, will take off their BiPAP just because no one likes the BiPAP. And I mean, I understand that, and plus a lot of these patients are on very high settings. However, when it comes to not being able to breathe or wearing the BiPAP, I would want to wear the BiPAP. That's just my thought process. So in the beginning, I said I wasn't going to give any medical advice whatsoever. So this is the one piece of medical advice I'm going to give is if you are in the ICU and you are on BiPAP, there's a reason you're on BiPAP. Please do not take it off. One piece of medical advice, don't take your BiPAP off if you're in the ICU. So with everything I'm already doing and patients decompensating and just going into patients' rooms over and over again, I'm busy. Respiratory short-staffed, nursing short-staffed, so we don't really have time for ourselves. We care more about our patients than we do ourselves, and that's why we're willing to sacrifice our lunch, bathroom breaks, all that other stuff, because we want to make sure the patients get the best possible care and we're not neglecting them. So that's basically what I do in the ICU as a respiratory therapist. So if you guys have any questions, you have any input on anything, please leave it in the comments below. Thank you guys for watching, and I'll see you in the next one.